Welcome. My name is Brad Monk. I'm a gynecologic oncologist from the University of Arizona Cancer Center in Phoenix. Welcome to Best of the Day. I'm coming to you from the first Energy Oncology meeting in San Diego, California. I'm here to talk to you about uterine corpus cancer, which some of you may know as endometrial cancer, but also includes the uterine sarcomas. And I was able to get the chair of the Uterine Corpus Committee, Dr. David Miller. Thank you, David.
Well, thank you, Brad. It's always good to chat with you.
It's great. Dr. Miller not only is chair of the Uterine Corpus Committee within Energy Oncology, but also is professor and director at University of Texas Southwestern Medical Center in Dallas, Texas. So that's great. I thought what we could do is move through the spectrum of treatments, beginning with primary treatment and some of the studies that we're doing in the adjuvant setting, talk about the results which are just emerging that these people can hopefully anticipate, and ultimately what studies are ongoing.
Of course.
The beauty, if there ever was one, and I'm not sure there is one, of uterine cancer is that it's amenable to surgical management, that a hysterectomy is generally an option, removal of the uterus and cervix, and almost always the fallopian tubes and ovaries. Is radiation ever an appropriate therapy for uterine cancer?
Well, it's used less. However, primary radiation therapy in very, very sick patients not suitable for surgery can sometimes be successful therapy. It's sort of a competing risk of what's going to be most harmful to the patient, their comorbidities or your treatment. But there's a small number of patients in whom surgery is a prohibitive risk, in whom we can use radiation therapy to treat the endometrial cancer. It's certainly not the treatment of choice, but it can be successful. Again, since most patients, particularly with early endometrial cancer, will die of other things, we always need to think about the impact of our usual treatment of just operating on everybody and trying to do the same operation on every patient, because a lot of them are sick.
So that would be external beam irradiation and brachytherapy?
Either one, and or both.
And or both, generally both. It'll stop the bleeding?
It can, yes.
Okay. So assuming that the patient can have a hysterectomy because of her health issues, does it matter if it's a laparotomy or whether it's minimally invasive surgery, either laparoscopy or robotic surgery?
Well, we've just finished one of the few randomized studies to evaluate minimally invasive surgery in treating human cancers. And that was our GOG LAP2 trial, where we looked at laparotomy versus laparoscopy. We'd already established that we can do the tasks, take out the uterus, take out the tubes and the ovaries, take out the lymph nodes. And so what we had to do was measure the morbidity and mortality associated with it. So we showed that it was a much less morbid procedure. Patients could get out of the hospital quicker, and then when we had sufficient follow-up, we could then see that the recurrence rate was not significantly inferior in the patients who underwent laparoscopic surgery, laparoscopic hysterectomy, laparoscopic lymphadenectomy.
Now the conversion rate, though, to laparotomy was relatively high when the laparoscope was used.
Yes.
And so I think many of us use robotics. Many of these patients are morbidly obese, and that it's, although not prospectively validated like the laparoscopic technique, probably robotic surgery has an even a lower conversion to laparotomy.
Oh, yes. And, because, with robotic surgery, probably because you have a whole team of anesthesia nurses that are experienced in putting the patient in very steep Trendelenburg. I don't know if there's anything that magic about the robot, other than you just have more mobility with your instruments. Right. You can do more things. You've got extra arms that you can hold back very heavy colon or omentum. But expert robotic surgeons can accomplish these procedures where a lot of us would be very, would be a little concerned if we were trying to do it laparoscopically.
There is one thing that's very special about the robot: it's cost.
Yes, much more.
All right.
Much more.
So lymph nodes. So we've been talking about removing the uterus and cervix and ovaries and tubes. You know, there are 2 randomized trials done in Europe, which would suggest that lymphadenectomy is not prognostic. In the United States, we still do lymphadenectomy, at least in patients that have a reasonable risk of metastases. The GOG wants to confirm or refute that. What's the GOG thinking of doing to maybe more definitively answer this question?
Well, you sort of have to look at what the goal is. So our goal of doing lymphadenectomy is to find metastases, assuming that we can treat those metastases successfully. And so we think we can do that often, not always. So, and that rate of metastasis is low. We don't do a very good job yet of figuring out who's going to have metastatic disease. So what overtreatment do you apply to the patient because of that low risk of metastasis? So you can either remove the lymph nodes and look at them under the microscope, which we as surgeons like to do. The radiation oncologist would tell you that we just radiate all those patients. And even some people think we should give a lot of those patients chemotherapy. And so what overtreatment do you offer these patients, since we have to try and target it? So we, as many surgeons, think that lymphadenectomy is probably less morbid than pelvic radiation therapy,
David,
and less morbid than chemotherapy.
You're implying that if the lymph nodes are negative, all those patients are cured.
Not all.
You just finished a randomized phase 3 trial where all the lymph nodes were negative, and half of those patients got pelvic radiation, and half got vaginal brachytherapy and chemotherapy, and they all had negative lymph nodes.
Right.
So we overtreated everybody, even when the nodes were negative.
That's what we're trying to figure out. It's a learning process. It's a learning process. Okay? Because you recall we had our GOG 99 trial, where we radiated a whole bunch of patients, and
all node negative.
All node negative, and it only benefited about 10 or 15% of those patients.
So this trial, GOG 249, that takes these patients, tell us who those patients are that are node negative but you're concerned about.
Well, let's look. Let's talk about our lymphadenectomy trial,
Okay.
and then because our hypothesis is that if you remove lymph nodes and you don't find cancer in the lymph nodes, that those patients will do better than the patients who get adjuvant radiation therapy and you leave the lymph nodes in.
Okay.
All right, and we have data, we have the long-term data from Portec, from the Norwegian trials, which very interestingly show that even though if you give radiation therapy and you can reduce the risk of pelvic recurrence, more patients die in the treatment arm.
Right.
What's the deal with that? Okay, and in the Norwegian trial, the death rate was significantly higher in the younger patients, and they had significantly higher secondary malignancies.
Isn't that interesting?
Because if you give
secondary cancers from radiation,
yes,
keep going.
If you give cancer treatment to people who don't have cancer, it's just toxic.
All right.
It's just toxic.
So tell me what you're going to do to fix this.
Well, what we're trying to do in a large multinational trial endorsed by the Gynecologic Cancer Intergroup is that we will take patients who we know have a higher risk of being positive lymph nodes, grade 3 tumors, elevated CA-125 levels, deep invasion on some sort of imaging, probably MRI. Those patients will be randomized between no lymphadenectomy or lymphadenectomy. Prior to that lymphadenectomy, they will undergo sentinel lymph nodes to also test if one is sentinel lymph nodes that we know works for breast cancer, melanomas. Is this a valid technique for endometrial cancer?
So half get no nodes, the other half get lymphadenectomy to begin with sentinel node. Okay, keep going.
Right. And so then the patients who have their nodes removed and those nodes are negative, those patients will receive no further therapy or minimal further therapy, because this is kind of an international collaboration and we've yet to work out those details. The patients who do not have a lymphadenectomy, those patients will then receive a lot of that unnecessary adjuvant treatment that we talked about.
So let me get this straight. So if I put my patient on that trial, and she's randomized to lymphadenectomy. So she gets an intervention that 2 randomized trials have told that she doesn't need. And when she has a deeply invasive grade 3 tumor or a serous tumor, I'm going to say, don't worry, your nodes are negative and everything is fine. I'm not going to treat you. Did I get that right?
Close.
I
See, because a lot of people feel very uncomfortable about this. But, it's an ongoing international negotiation. Clearly, most of these patients are going to be in what we call our high intermediate risk.
So tell us who those are, and then you tell us about this 249 study.
Okay, so the high intermediate risk group of patients come from our GOG 99 patients with patients who have lymphovascular space involvement, grade 3 tumors, deep myometrial invasion, and then we have an age stratification because age is also a important predictor. If you're less than 50 and have 3 risk factors, 50 to 70, and 2 risk factors, or greater than 70, and 1 risk factors, that sort of puts you in this high intermediate risk group of patients.
Or a serous cancer and cervical involvement.
Yeah, and so this is really the group of patients who
are not going to get any treatment on your lymphadenectomy trial.
Who are getting a whole bunch of unnecessary treatment, and we're trying to figure out which treatment is the most unnecessary. Lymphadenectomy or radiation.
I respectfully am interested in what you're saying, but I'm not trying to poke you in the eye here.
You can do that. You do it all the time.
So you just completed a randomized phase 3 trial of this high intermediate risk, vaginal brachytherapy and chemotherapy, and pelvic radiation, and your next study is going to have no treatment.
Well, if you look at the sequence of a variety of studies, both and particularly internationally, our treatments are getting smaller.
Right.
You got our PORTEC trials. We start with pelvic radiation therapy, and then we go pelvic radiation therapy is no better than brachytherapy. And so the next European PORTEC trial is now 2 doses of brachytherapy versus no therapy.
And that's called PORTEC 4.
PORTEC 4.
So I think that's a good explanation, but I think also my rebuttal highlights some of the controversy.
Of course.
So I think what we need is better molecular understanding.
Absolutely.
And to be clear, this 249 trial, which you've heard about, is going to be presented at the Society of Gynecologic Oncology next month in March in Tampa, Florida. So stay tuned. Hopefully we'll come to you from Tampa, Florida, and talk to you about these new findings. So the Human Cancer Genome Atlas has just completed an analysis of endometrial cancer.
Yes, I did.
Are there any lessons learned there? Because it's all about molecular profiling.
Well, we assume, and we certainly hope so. And so in the very large genomic profiling they did of over 500 patients, they sort of identified 4 prognostic groups. They had a group they call POL ultra mutated. Okay, sounds bad, but this is the best prognostic group.
All of them were cured. Yeah, that's amazing.
So these are the patients who just need a hysterectomy.
Right.
Okay, assuming we can find some biomarker that can reasonably identify these patients. And then there were 2 sort of intermediate risk group of patients. There were those with what do they call hypermethylation. And then
the Lynch syndrome sort of mutated
kind of that
genes,
group of patients, and then a group they called copy number low, these 2 intermediate groups, and then the worst prognosis group were what they called copy number high, lots of gene alterations, okay? And so this group is the one I found particularly interesting because they called these serous-like. They didn't call them just serous. They were serous-like because they involve all the serous cancers and about a quarter of the grade 3 tumors.
Right.
So just using the phenotypy of serous or seriousness is a insufficient predictor.
So said another way, histology is not really what it's cracked up to be. It's more the molecular characteristics.
Right. And so these patients had lots of P53 alterations. They didn't have much microsatellite instability. They had low ER/PR receptors. And so this was a worse group of patients who looked genomically very similar to serous ovarian cancers and a basaloid type of breast cancer.
So why don't we do a molecularly informed study?
We hope to do those.
All right. Okay, good.
We have to find targets that predict sensitivities to our interventions, and we have to have interventions that actually work where they think they work.
I think that's a good summary. So you were very strategic in completing a study that was presented at the Society of Gynecologic Oncologists, a study that really defines the global standard for treating systemic disease. Tell us about that study. I think it's called GOG 209.
GOG 209, that was the largest chemotherapy trial in endometrial cancer that had been conducted to date, about 1,400 patients. And it was compared our previous best chemotherapy, which is a 3-drug regimen of paclitaxel, doxorubicin, and cisplatin, with a very popular regimen in the community, carboplatin and paclitaxel. And so the outcome was for survival. We had patients with measurable disease, had patients with advanced stage patients with minimal residual disease, and the net result of the study was that carbotaxol was not significantly inferior to TAP. The response rate for the patients in the measurable disease was 50% in both arms. The median progression-free survival was about 14 months in both arms. I think the median overall survival was 32 months in the carbotaxol arm and 38 months in the TAP arm. There was significantly more neurotoxicity as we expected in the TAP arm and less in carbotaxol. So when you looked at the, overall it was a wash, but the toxicity profile in carbotaxol was much better.
So I saw a patient last week who was received in the metastatic setting doxorubicin cisplatin. And I said, oh, did you hear about Dr. Miller's trial? Doxorubicin paclitaxel cisplatin versus carboplatin paclitaxel, and it was non-inferior. Mm-hmm. And the guy says, yeah, but he didn't study doxorubicin cisplatin.
That was a couple decades ago, or at least a decade ago.
So doxorubicin cisplatin would not be a standard regimen?
No. Because we showed that TAP was better than doxorubicin cisplatin.
Thank you.
About 10, 12 years ago.
Great. Okay. Mm-hmm. I just thought I would clarify that.
So you can enlighten your colleague.
I'm just trying to enlighten everyone. Uh-huh. Probably one of the most exciting molecularly targeted pathways, which does not have a biomarker, is angiogenesis.
That's right.
So
we need a biomarker.
You worked, help me.
Well, we do. And we have a great resource for that, our GOG 210
Tell us
trial.
what that is.
GOG 210 was a extensive epidemiologic study of presumed early endometrial cancer patients. We have banked tissue, urine, blood from 6,000 endometrial cancers.
They're all surgically staged with prognostic
all surgical stage, extensive epidemiologic surveys on those patients. That's where you're going to find your biomarker.
I love it. That's constructive. So probably the most active targeted agent is bevacizumab.
So far.
And so I just wrote down on a note here that the response rate was 13.5% with a progression-free survival of 40% for 6 months or greater.
Just like many of our chemotherapies that we've tested since we found that paclitaxel was active.
Right. Interesting.
So very impressive. That's why we incorporated that with carboplatin and paclitaxel in our subsequent trial, 86P.
Which has not been presented yet.
Not yet. Soon we hope.
And how about TKIs, anti-VEGF TKIs?
Also a interesting pathway that we need to evaluate.
But you've done it, right? Didn't you do cediranib?
Yes, we did. That study is completed. We have the results. And you should come to SGO and find out the results of that trial.
So I got to go to SGO twice for your high and immediate risk, randomized phase 3, and the cediranib phase 2.
And a couple others
we
can talk about.
All right, so just in the few minutes that are left, let's discuss non-epithelial tumors, although carcinosarcoma, I guess, is an epithelial tumor. What is the standard treatment for metastatic carcinosarcoma, and what trial are you doing now?
Well, the GOG standard, which has been proven to be superior to single agent, is a combination of ifosfamide and paclitaxel. That's a toxic regimen, takes a couple days, tough on patients, and similar to the GOG 209 trial, we ask the obvious question is, can't we give carboplatin paclitaxel? Might that be just about as good? So a lot of people were very skeptical that we could conduct a large randomized trial in what's considered a rare tumor. But we've put now almost 600 patients.
But you included ovarian too, right?
Well, that's barely like 50 or 60 patients. We did include that because...
But that's not why we want.
Yeah, no, these are all mainly uterine carcinosarcomas. We wanted to include more ovaries and a few fallopian tubes, but the NCI was not as interested in that.
So that'll create the global standard in carcinosarcoma.
Yes,
ideally, get us away from ifosfamide paclitaxel.
That's right.
All right, well, let's talk in closing. What's the standard systemic therapy for leiomyosarcoma?
Well, we're trying to define that. We have a couple studies, one GOG 250 that we completed. We had an active regimen, gemcitabine and docetaxel, which the GOG as well as the SARC group had shown to be active in leiomyosarcomas, both in primary treatment, upfront treatment, and even in the salvage setting.
Right.
So we did GOG 250, where we added your favorite drug, bevacizumab, with or without bevacizumab, and we've completed that study. That too is going to be presented at SGO.
Really?
So stay tuned.
That's great.
Stay tuned.
So the current standard generally is docetaxel gemcitabine. You finished a phase 3 with Bev, and I got to go to the SGO.
Yes, you do.
Okay.
So now we're doing the tough study.
I was going to say, what I see, in fact, you probably saw all this arguing, consternation about morcellation of uterine leiomyomas, because some of those are leiomyosarcomas. So it was in Lancet Oncology, it was in the New York Times, the Society of Gynecologic Oncologists made a statement. To be clear, not every uterine mass is a leiomyoma. But when it is a leiomyosarcoma and it's completely resected, and again, you shouldn't morcellate those if you can help it, but when it's completely resected, does that patient need adjuvant therapy?
That's what we're trying to figure out, because we know those patients have a high risk to recurrence.
Right.
Nothing we have done.
Particularly when they're morcellated, but keep going.
That's even worse, but that's also something good to talk about. But in patients where you take out what you think is uterus confined leiomyosarcoma, those patients have a 50% risk for it to come back, and those patients are not going to do well. They are going to die. We have a study that derived again from SARC data in peripheral leiomyosarcomas, 4 cycles of gemcitabine and docetaxel followed by 4 cycles of doxorubicin. And so we've entered into an international consortium.
And what's in the control arm?
Observation.
Well, okay, keep
That's
going.
the standard of care. Well, I mean, we have not yet shown that anything is better than observation.
I'm not poking you in the eye yet.
I'm sure you'll try. We have not shown anything better than observation.
I think that's right, though.
And so we're doing the tough study, GOG 277. It's part of the international.
Observation, docetaxel, gemcitabine, and doxorubicin. 8 cycles total, 4 of each. Good luck.
It's tough. It's a tough choice.
But an important clinical question.
Yes, it is.
That we have to do.
It is.
That's right.
So it's going to be heavy lifting. So we hope serious investigators will help us accomplish that.
So I want to congratulate you. You have changed the global standard. With all due respect, you got to still work on the lymph node thing. Okay.
We're going to sort it out.
But you have...
Because there's tremendous bias. There is tremendous bias.
You're the one that said unnecessary therapy 10 times. But
I know.
I understand.
I know, but I have to keep saying it. Repetition is required for learning.
But clearly, you have determined the standard of care in chemotherapy in metastatic endometrial cancer, carboplatin paclitaxel. I thank you for that. You've been a leader in the development of biomarkers and targeted therapies We're going to hear more at the Society of Gynecologic Oncologists. You're also working on adjuvant therapy, going to hear it at the Society of Gynecologic Oncologists. You're trying to work on the sarcomas. We're going to hear it at the Society of Gynecologic Oncologists. So I thank you. It's really only the GOG, really, that can do large, complicated trials efficiently and quickly. There are other groups that can do them, but not to the level that you can do them.
No.
This has been your career focus, and I'm very grateful, and it's been my honor to chat with you.
My pleasure.
It's great. Thank you very much. From the Energy Oncology meeting in San Diego, California, this has been Best of the Day. So long for now.